Welcome to the Red River Medic Podcast, breaking rules, challenging norms, and changing EMS for the better. On this episode, we hear from a physician and EMS advocate from Arkansas, Dr. Brandon Morshedi. We talk about how pre-hospital medicine advances from concept to approved protocol and practice, why everyone in EMS needs to be an advocate at their local, state, or national level, and why we should support and join organizations such as the National Association of EMS Physicians. Join us as we dive into today's episode on how to advance paramedic practice in Arkansas or whichever state you are listening from. Join the conversation on advocacy as we try to actually make EMS better, one real conversation at a time.
Welcome back to another edition of the Red River Medic Podcast. I'm your host, Paramedic and EMS Director David Grovedal. This show is for medics who aren't afraid to stir the pot, ask the hard questions, and challenge the way we've always done it. So today, we have another member of the Red River region of the United States, a board-certified emergency medicine physician, an EMS medical director, an EMS advocate at the state and national level, a paramedic, and a slew of other certifications and accolades, Dr. Brandon Morshedi. Welcome to the show, Dr. Morshedi.
Thanks, David. Appreciate the invite.
So, I'm relatively new to our state, and you are definitely somebody who has been around the state for a long period of time. We've talked about your journey from an EMT all the way through to medical director. Why don't you give our listeners a little bit of an insight as to where you started and how you got to where you are today?
Yeah, and so actually EMS was not my first choice. I played a lot of sports growing up through high school, loved baseball, and I wanted to be a physical therapist, wanted to work with athletes, and went to college, undergrad, as a physical therapy major. And it was my junior year that September 11th happened. And I thought at that point, like, all right, being a PT is going to be cool, but I need to also do something to maybe give back to my community a little bit. So I went down the road to my local fire department and I joined them. They trained me up as a firefighter, became an EMT, started working on the ambulance part-time as I was working towards the physical therapy career path. Got into PT school, got my doctorate in physical therapy, worked the ambulance the whole time, part-time. And when I started working as a PT, I enjoyed that, but I also enjoyed working on the ambulance. So I kept doing that part-time, even while working full-time as a physical therapist. I enjoyed it enough to eventually, one day, several years later, decided to take the next step to become an emergency medicine physician. Really, I wanted to become an EMS physician. I went to med school to be an EMS doc, and I got my paramedic along the way, and actually still carry it to this day. I think 24 years in EMS. And medical director is kind of my primary job, and then work a few shifts and a bunch of different ERs around the state. But yeah, it was kind of really a third career, I guess, getting into this what I'm doing now.
Now, you and I met a few weeks ago at our state's medical direction conference, where there was a lot of great conversation about what's going on these days in Arkansas. And you are integral in this new era of Arkansas EMS, if I can call it that. We have a new EMS advisory group and some exciting things coming down the pipeline. Can you talk to us a little bit about the structure of EMS here in Arkansas?
Yeah, so a little bit of background. For the decades, we had the Governor's EMS Advisory Council, and it was a group of, I believe, 19 professionals that were contributing to kind of the growth of EMS, and they relied on a lot of input from different committee level structures around the state, air medical and EMS education and data committee, entities like that, trauma and stuff. And they would then try to turn around and figure out ways to improve EMS from there, make updates to rules and regulations and statutes and scope and stuff. This last year, the state legislature decided to give that entity quite a bit more statutory teeth and took the EMS Advisory Council and abolished it and created an EMS Advisory Committee. Now, the concept of a council versus a committee sounds like semantics, like it shouldn't be that big of a jump, but actually it was pretty significant because forming a committee, the way that the state works and the authority that's given to a committee, is this group now has the statutory teeth to make updates to rules and regulations, and they will advise through recommendations and written advisories the Arkansas Department of Health, and if needed, through the Secretary of the Department of Health to the state legislature to make statutory change that way. So there's really nothing that we won't be able to positively impact through understanding how the system works and building a robust subcommittee structure under the committee, of which we will all be serving on these subcommittees to try and make progress and improvement around the state for all the men and women who work in EMS and the patients and the communities that we serve.
Now, sometimes EMS providers don't necessarily realize or understand exactly how scope of practice works. And if you're in Texas, paramedic scope of practice is a lot different than in Arkansas, which is a totally different format that is in North Carolina. And so talk to us a little bit about who gets to decide what a paramedic can and can't do, and what is that process in various states?
So in all states not named Texas, there is the National EMS Scope of Practice. It was last updated, I believe, 2019. They set basically you have every license level, so EMR, EMT, advanced EMT, paramedic, and then they go through all the list of interventions and medications and procedures and skills and say what each level is allowed to do within their scope. The states take that document from NHTSA, Office of EMS, and decide this will either be our floor or our ceiling. And from there, they can modify the scope with individual statutory changes to say, we'll let our EMTs do supraglottic airways. We make that a statutory change. Texas says we will do whatever the medical director says we can do, and if they want their crews to take out gallbladders and do cranial burr holes, then that's on the medical director at that point. Texas does whatever they want through what they call delegated practice, meaning it is completely on the back of the medical director. All the risk, all the liability, and all the fun and reward, depending on the size of the service. Working in Texas for almost 9 years as a physician and EMS medical director, it was somewhat terrifying on one hand and liberating on the other to be able to do whatever we wanted with our crews. Here in Arkansas, we have the Arkansas Department of Health, the state rules and regulations. We do follow the National EMS Scope of Practice as our barometer for what each licensee is allowed to do within their scope. And it is up to this new committee to take it line by line and say, all right, do we want our EMT basics to be able to do CPAP or supraglottic airways? Can we let our paramedics initiate blood? And these are the things that the committee will then take to the Department of Health and make these changes happen.
And you said my two favorite words, whole blood. And so a lot of our listeners know I'm a huge advocate for it. Have started at several places. We just had a committee meeting. I got to be an outsider kind of listening in with our great friend Randy Schaefer out of Texas, where I'm not going to say they pioneered whole blood, but it definitely was the birthplace for the pre-hospital, and they did a lot of work that the rest of the country has grabbed onto, and is definitely a very big trend in EMS agencies. And so it's very exciting in Arkansas. That's one of the first tackle things that you guys picked as an advisory council. What is it about whole blood that I know you're very passionate about, and the committee seems to be very, very passionate about?
Yeah, we had our very first EMS Advisory Committee meeting in early November, and we will meet quarterly. And we are building a subcommittee structure. The very first subcommittee that we created was an ad hoc subcommittee. Ad hoc meaning they have one singular focus. This is the one task that they'll focus on. It's an ad hoc subcommittee on pre-hospital blood. Arkansas is one of, I think, 4 or 5 states left in the country that paramedics don't have the ability to initiate blood within their scope. We do it on our helicopters because we have nurses on the helicopters, and that's how we can get away with having blood on the helicopters. But paramedics can't initiate blood. They can push paralytics, but they can't give a life-saving component or whole blood therapy. So obviously this is something that no one in the state argues the science behind it. Everyone agrees, yep, blood is important. If you are bleeding, you should receive blood to replace it, not crystalloid. So this subcommittee, we recognize the obstacles with making blood available in the paramedic scope, with creating a training curriculum, a credentialing program, with developing mechanisms for funding startup costs for blood through like the Rural Health Transformation Program that's coming early next year, those funds, as well as other grant funds, and also the sustainability of a blood program. So this subcommittee was formed, and then it had its first meeting this past Monday. And so I'm vice chair of the EMS Advisory Committee, but I'm the chair of this ad hoc subcommittee. And we have 5 members on the subcommittee. But as you stated, the meeting was open to the public. And that's what I love about the way we're creating our subcommittees is we invite public input, stakeholder input. We are building this for the public, so we want the public's input on it. And we had about 35 people, I think, on that meeting, everybody contributing. You were able to give some good input as well. And we are going to build the blueprint for how to make this happen. We'll have a subcommittee meeting. We had one this month. We'll have one next month. We'll have one the following month. And then the work product that we're going to produce, the written document, will be the start to finish blueprint, I guess, if you will, that the agencies can just take the shrink wrap off of it and implement it at their agency. So we're creating the process for them so that it can be subject matter informed or subject matter expertise informed. It can be evidence-based. It can be standardized. We're all on the same page, speaking the same language. You know, we set the bar for how it should be done, and using examples of the STRAC in Texas, which, you know, that's I was there when they started the program, I think around 2017, and they are the shining platinum example for how to do a blood program where you are good stewards of such a precious resource. You minimize waste. They did it so well that the state is paying for it now. And that's what we want to create here. We've got so many of our neighbors that are doing it. I think Arkansas is well positioned, that we've seen the things that work and don't work. We understand the obstacles we have here, and we're the perfect size state, I think, that we can build this one program that should fit for the majority of our agencies, and where there does need to be some individualization, we'll make it a bit more general with just best practices so we don't pigeonhole anybody. This document, I mean, I've already started working on it after our meeting on Monday. I've got several pages typed up, and it's going to be a really nice product when it's done at our next full committee meeting in March. The goal is to have it done by then.
So one of the things that I know we talk a lot about in Arkansas is we have that urban environment. We have that rural environment. And in the area that I currently operate in, we have that super rural environment. So it is really important that we don't develop just one model, that certain different areas have different needs. So that's a great thing. And that representation is seen on the advisory committee. It's not just physicians. It's not just administrators. It's not just state people. It really is a mix of all the different voices that need to be heard. Talk to me a little bit about kind of the different people that are on the committee.
Yeah, so I mentioned there were 19 people on the original Governor's Advisory Council, and when we were building this idea of a committee, we thought that the 19 was a bit excessive. We initially had 9 when the first draft of this bill came out. There was an emergency physician, an EMS medical director, so those are the only 2 physician spots. There's a civilian, like a consumer role on there. And then we ended up with 11 total. So the other 8 on there are all EMS professionals. The different sectors that are represented, there's private EMS, public, like municipal EMS, fire-based EMS. We actually advocated to get EMS educator on there because I thought it was important if you are changing a scope of practice or standardizing protocols, you should probably have someone at the table that understands the impact on initial education, because that's going to have to roll back into training. We have air medical EMS. We have both the paramedics, and there's a EMT slot on there as well. So there's 11 total, and we feel like not only the different sectors being represented well, but also the regions of the state they come from, like you mentioned. And so I think our Department of Health did a really good job with the first iteration of this committee. We served 2-year terms. I think I remember we could serve 2 consecutive terms, but then we have to rotate out, so a max of 4 years. So you'll see different faces roll through here and being able to contribute. So certainly we would encourage the EMS professionals around the state stay engaged with the committee, watch our meetings. They're all open to the public. See the things we're working on, contribute now with your input, but then also when we solicit nominations for replacements, come join. This is where you really make a difference with improving the systems of care around the entire state. So it's very satisfying work.
And that's one thing, if I could jump from or scream from the mountaintops to tell our providers is that you may feel like your voice isn't heard. You may feel like that your voice doesn't matter, but it really does. You have the opportunity to have a say. Like you said, you can listen in on those meetings. You can listen in and provide feedback. And if you want to serve, the time will come where there will be a call for you to be an advocate. What are some other opportunities in Arkansas that we could potentially, as providers, have a say in the system? I know you're a member of a couple of groups.
You got several options. So the Arkansas has a state chapter of the National Association of EMS Physicians. While it's a physician group, about 1/3 of the membership, both in the state and nationwide, are professional members, licensed EMS clinicians, EMTs, paramedics, quality managers, educators, service directors, things like that. So certainly we would invite you to join the National Association of EMS Physicians, which for professional members is dirt cheap. And you get access to all kinds of good resources. The Pre-Hospital Emergency Care Journal, it's the #1 journal for NAEMT, NREMT, NAEMSO, NAEMSP. We do a lot of joint position statements with American College of Surgeons and ACEP in there. So you get access to all that literature in there, podcasts, textbooks, discounts to annual meetings. And then it is free to join our state chapter. We have no chapter dues. And then you can get involved at the state level. Locally, I would figure out the leaders in your RAC, your Trauma Regional Advisory Council. The way that Arkansas developed their RACs is also not just for trauma, but also for STEMI and strokes. So it would be good to get involved with the RAC. You can contribute to case reviews and local protocol development, kind of the systems of care stuff locally there. So those would be the 2 lowest hanging fruit things to do.
Yeah, absolutely. And a lot of my medics will ask me, well, when you talk about the literature, what are you referencing? And I constantly will refer back to the pre-hospital journal through NAEMSP. That comes out monthly, always has some great articles in it in literature. That's probably one of the preeminent sources to look at for research.
Yeah, your listeners, if they're listening to this podcast, then they're fans of podcasts. I would definitely recommend doing the PEC podcast because they will highlight certain articles or the entire issue. Just listen to a couple of them and you'll get a sampling of the quality of literature that comes out in this journal. I think I heard at one point it was the number 7 most referenced just emergency medicine general, period, and it's specific to pre-hospital care. So really, really good stuff in there. If you're looking to do something at your agency, build a new program, what is this intervention going to do versus another one? You can probably find the answer to that in that journal at some point over the last few decades.
Absolutely. So what are some other great things that are happening in Arkansas? I know we've talked about blood is on the horizon. Maybe we'll start to see some pretty significant movement this year. What other kind of things should we be looking forward to?
2 years ago, we had the legislation come out about the treat in place initiatives here. So the emergency triage, treat, and transport, or ET3, that initially came out through CMS back before COVID, that was shut down a couple of years early. I think in Arkansas, we recognize the value that it potentially could have brought, even though there were some challenges with trying to enroll in that or apply for that as an agency for the federal program. Here at the state level, they passed some legislation that if you meet certain criteria and you are an insurer that provides insurance to citizens here in the state, that you will pay EMS agencies who meet these criteria for a treatment in place, a treatment on scene, or a treat and release. Different agencies call it different things. We go out on scene. We are healthcare, right? We're not just a transportation commodity. No, we are healthcare. We go out, we assess you, we maybe give you some interventions. You felt bad, we made you feel better. We probably used some equipment, some supplies, some expendables. And historically, you're only paid for the patient that you take to the emergency department, the most expensive resource in all of healthcare, whether they needed it or not. So the initiative here in the state is that EMS agency can do a telemed consultation with the physician medical director, and we can talk about that patient, and I can meet the patient and talk to them, and hey, I know you were feeling a little bit short of breath, you were wheezing, they gave you a breathing treatment, you feeling better now, your oxygen's looking great. How are you managing your asthma at home? Do you have an inhaler? Have you been sick recently? We have a 5 to 10 minute conversation. I make sure they're good, and that's it. You all of a sudden get paid for that trip out there, even just like you took them to the hospital, even though you did not take them to the hospital. I think that is not a lot of agencies are taking advantage of this right now. Probably my opinion here is because you don't have a lot of engaged medical direction at a lot of these agencies. There's easily a half dozen medical directors that I consider my friends and colleagues are very aggressive, but there's a lot of agencies that rarely see their medical director, and it's a tragedy. I would venture to guess that you'd see the quality of care significantly improve if you had more engaged medical direction at some of these agencies. But that is one thing that we're able to offer at my agency, because we talk to our crews and we offer telemed options to them. And it's a good way to recoup the cost for the 15 to 25% of calls that you don't take to the hospital.
Yeah, that ET3 model was probably a little ahead of its time, and maybe structurally there was some challenges with the way CMS had set it up, which made it a little bit difficult to enroll. I know I was with an organization that was an ET3 approved program, and that treatment in place model had some great vision to it, and I was disappointed to see it end ahead of its time. But I know the spirit has not died on the EMS side, and we continue to push, just like we continue to push to change our model from being just a supplier to being a provider. You talked earlier about words have meaning, and so it does mean something. In government, words do have meaning, and so just like a committee does mean something. Yeah. Supplier and provider are two totally different things in the eyes of the federal government. So now I know you're active at the federal level, and you've been participating and doing some work at the federal level. How's that going?
Yeah, I was lucky enough to be appointed as the EMS Physicians Sector Representative to the National EMS Advisory Council in 2023. It's a 2-year appointment through the Secretary of the Department of Transportation. The National EMS Advisory Council, or NAEMSP, has been around since 2007. They exist to advise FICOMS, the Federal Interagency Committee on EMS. Now, I don't think most of the EMS professionals out there, I mean, they probably read on page 1 of their textbook that, yeah, you're under DOT and NHTSA, and everybody's like, well, that's really weird. Well, we're like truck drivers out here. But it's really, the DOT is not really the agency that oversees and regulates EMS by itself. It's really FICOMS, the Federal Interagency Committee on EMS. And interagency meaning there's all these different cabinet level departments that contribute a representative to the FICOMS committee, and that committee is who regulates or oversees EMS at the federal level. So you've got Department of Health and Human Services, CMS, Department of Homeland Security, USFA and FEMA. You've got obviously DOT and NHTSA, the Office of EMS, the FCC, DOD. I mean, all these different federal cabinet level departments make up FICOMS. NAEMSP advises FICOMS through written advisories and recommendations, because FICOMS is a bunch of feds. They don't necessarily do EMS, but they make decisions about EMS. So they said, hey, we need a group to help us with this. So NAEMSP is 25 different members, 25 different sectors. There's emergency medicine physicians, EMS physicians, trauma surgeons, pediatric physicians. So there's 4 docs. The other 21 are usually paramedics, and there's private and volunteer, there's fire-based, there's state and local legislative officials. So there's usually an elected official that's appointed to that. There's 911 telecommunicators on there, state EMS officials, tribal EMS, hospital-based EMS, hospital administration. There's really not a sector that's forgotten about on NAEMSP. 25 members make this full council up, and then they have 6 subcommittees underneath them. And those subcommittees, I was on 3 of them, and we pushed out about 25% of the advisories that have ever come out of NAEMSP since 2007 came out during our 2-year term. We were cranking them out. Very important works about, funding and essential service designations, talking about mental health, talking about resources, talking about safety and violence against providers. And you can just go on ems.gov to the NAEMSP page and just browse some of the advisories that have been written and published. So that was so much fun being a part of that. I had no idea how much of an impact you could make until I got appointed to that. I was lucky enough to be voted as chair for that NAEMSP going forward for the next appointment. It's a 2-year appointment. You can do another 2-year term. So we were actually waiting on our reappointment back in March or April. And then, unfortunately, the entire council got terminated to basically wipe the slate clean to start over, which was really unique because they usually turn half the committee over every 2 years, so there's continuity for the work that's being promulgated. But this one was unique in that the entire council was terminated to have to reapply for your seat. So they did put out the notice through the Federal Register for new applications that closed a few months ago. Talking to the director of the Office of EMS, it sounds like it's going to be about another 4 to 6 month window of vetting all these new applicants, which is usually what it takes, is about 4 to 6 months. And they'll probably seat a new council by late spring, we're hoping, because there was a lot of good work happening at the federal level. We were not allowed to talk about the work we did on NAEMSP because we weren't allowed to represent NAEMSP individually. We only could do it as a council. So if there was any silver lining to us all getting terminated, we were actually able to go out and talk about all the good work that we did. And I think a lot of people really had no idea what NAEMSP did. I heard the comment a lot, well, I mean, I've been a medic for 30 years. I've never heard of them, so they must be useless. Really? Or maybe you're just not informed about who actually drives the decisions behind this profession. So we were able to basically advocate for get engaged, be involved, register on ems.gov, listen to the meetings, pay attention to the work that's being done, because we need your voice in there to contribute. So it was really kind of gratifying being able to go around, myself and several other members, talking about the work that was done. If Obviously, a lot of us put in, again, trying to get back on the committee because I had 18 advisories in the hopper that were at different stages of development, 18 different things to advise the federal government on how to make our lives and our profession better. I have all those documents still. I would love to get back on and finish them, but if it's not me, then whoever is the next EMS physician on NAEMSAC, I'll just give them all that stuff because the work really was that important. And I really, really hope that the EMS professionals out there pay attention and stay engaged in that. There's 1 million licensed EMS professionals in this country, about 500,000 nationally registered. There were about 14,000 that subscribed to EMS.gov listserv for getting emails. And there were about maybe 400 to 500 that stayed engaged with the meetings and actually listened. And then each public comment period, we'd get maybe 2 to 5 public comments. So really just not a lot of people understanding how to make their work life better with being able to drive the narrative on change with the NAEMSAC advisories.
And that really does bring us full circle. So how do you affect change? If you're an Arkansas paramedic, if you're out in County X, how do you affect change? And it really comes down to have a conversation, engage and participate. And so get on a committee. Listen in to the committee meetings. It doesn't cost you anything to log in when the EMS Advisory Council has their meetings. It doesn't cost anything to the next time you're at the conferences to go seek out the Brandon Morshedis of the world and to say, hey, can I have 5 minutes to bend your ear? What's going on these days? Because you are a conduit for us as paramedics to advance the things that we want, or maybe even for us to ask questions. So important that we engage as well and not just sit there on the sidelines and complain about how EMS does or doesn't do this or why not. We have money and other public safety agencies or types are getting all of the money. Maybe we need to start advocating for ourselves.
Yep.
And really drive
gave
that.
A keynote talk at our state EMS conference back in August about EMS advocacy because we're not good at it. We just I'm going to go clock in and do my job and we're going to save lives because that's what we do. And we're not going to tell anybody about it. And then we're going to complain that nobody knows what we're doing. You got to learn how to advocate for yourself and invite your city council member or your county commissioner to come do a ride out with you, come do a station visit, let them see. So when you talk about needing a subsidy of $10,000 to fund salary and equipment, they're not looking for, well, who can come in here and do it without a subsidy. So get involved and go meet the decision makers and share with them what you do.
Yeah, I have heard many times over, you don't have to be the smartest person in the room. Surround yourself with those who are. You don't have to be the most powerful person in the room or the one who actually does it. Surround yourself with those people who have the opportunity to make things happen. And so teach that a lot to EMS directors and supervisors. This advocacy is not a director job. It's an everybody job.
Yep. That was the exact message that I preached back in August at the state conference.
So I'm very active in NAEMSP, the National Association of EMS Physicians, and you talked earlier a little bit about our chapter. There's some great opportunities for EMS providers. You want to build a credential, have something to put on a resume. There's a great credential out there, the famous. I love the credential. It's the famous credential, easy to remember, but it's about being a participating member of NAEMSP over a 3-year period, participate in an activity, do some different participation projects and different things. So what's going on at EMSP here in North Carolina? What's some things that maybe we as providers, we could get involved in?
Well, you said North Carolina, Arkansas. So yeah, in Arkansas, we're focusing, we've done a couple different initiatives here. We hosted and taught a Foundations of Medical Oversight course that was designed to engage medical directors who maybe don't have any background, not only in emergency medicine, but EMS, and teaching them the kind of 5 pillars of what it means to be a medical director and how to be engaged and provide good quality of oversight. We actually had a lot of quality managers and service directors and educators that came to that as well. So that was a really productive class. Most recently, just at the state conference a few weeks ago, this year we did 1 full day kind of quality improvement and safety course. It's a bit of a abridged version or a sneak peek of the full pre-conference at the annual meeting at NAEMSP every year. But this 1 day, full day session here teaches these EMS agencies, if quality manager or whoever it is, what does it mean to do quality improvement? What's the difference between QA and QI? You got to know these terms. What is a PDSA cycle? How do you make progress and change happen? And that all came from NAEMSP down through our state chapter, and we deliver that course out to our people. We're engaging with the emergency medicine residencies in Little Rock at UAMS and up in Searcy. We're doing EMS days for them as part of their conference education. We're teaching them what is EMS, why do you need to be engaged with them, what's their scope of practice. Because these ER docs are going to graduate and go out, and maybe they think they know what EMS is, but do they really know the difference between an EMT and a paramedic? Do they understand what the scope is out there, what they can and can't do? When an EMT brings you a patient and you're yelling at them that there's not a IV and they didn't get any meds, and how come you didn't do this or that? Well, you probably don't know the difference between an EMT and a paramedic. So we're teaching them. We're making sure that no resident graduates without having a good understanding of what EMS is and what they do. I think that will build a better working relationship, kind of the multidisciplinary team approach to emergent care. So our state chapter is involved in that. We're doing MCI drills out there, tabletop disasters. So yeah, the leadership of our state chapter, these are the things we've come up with. We would love anybody listening who lives in the state to also join, and we'll listen to whatever ideas you have about how to improve EMS and emergency medicine and EMS medical director, kind of that whole relationship where we're improving the system of care for emergent patients.
Yeah, I took that NAEMSP quality course this last go around, and I've taken it before. There's so much information given that I took it the first time with the great Dr. Remley Crow and Dr. Joey Grover and Mike Tagman, man, and just talk about the back of your head just blowing off. So much information, so much great information. And then being in the class this time, I learned totally new things that I'm sure were taught the first time around. It was just, I was in so much information overload that I probably didn't pick up on everything. But it's funny, I was on my way to Little Rock to take that class, and I was listening to a podcast, the EMS Lighthouse. And in that podcast, one of our Texas friends who leads that podcast, Dr. Jarvis, and he was talking about ACOG and NAEMSP having a position statement. And met one of the physicians there in Little Rock who she started talking about, and I thought, man, I just listened to a podcast about this topic this morning and this position statement. And there's a push in Arkansas, and there she goes. Dr. Morshedi and I are working on elevating EMS protocols across the state. And she said something really, really profound to me. And it was, if Arkansas was its own country, we would be 99th in the world in infant and maternal fetal
mortality.
Yeah, death. And we talk about deserts, ambulance deserts, where we don't have lots of ambulances or long response times for those primary units. And we have that with OB-GYN and coverage in Arkansas. And so really working on protocols to build up to be able to address some of these risk factors. So EMS does have some significant impact. We're not just a transport agency. We're not just a toter from point A to point B. We have the ability to really impact care that's provided.
Mm-hmm.
And so,
Yeah, so funny story about Dr. Manning there. I missed day one because I was in DC actually doing the lobbying work. And so I missed her talk. She's actually my cousin. Small world. And so yeah, when I knew I wanted to update our protocols for my ground agency on how to address obstetrical and gynecologic emergencies. I mean, things as simple as how do you define preeclampsia? Should that be something we start treatment on in the pre-hospital setting, versus waiting until they get into the emergency department? Do our crews even know that a blood pressure of 150 over 100 with a mild headache is a very bad thing for a pregnant patient? If you're not pregnant, okay, whatever, just control your blood pressure, take a Tylenol. Maybe you give them some misguided healthcare advice on scene to earn that refusal. But this is why Arkansas is literally 50th in the nation in maternal mortality. So I knew when I moved back here that we wanted to fix this. I reached out to her. She's the chair of OBGYN at UAMS. She actually put me in touch with some of her other faculty that work underneath her. And we developed not only a new updated protocol, but a whole training curriculum for how to teach our crews this. And where the local critical access hospitals and docs that work in those ERs probably don't even understand this, our crews are out there diagnosing this and managing this. It cost me 10 cents to put oral immediate release nifedipine on the ambulances, and we're giving nifedipine, and my crews understand labetalol is second line. We know how to make these diagnoses. We know how to recognize it. We'll do our part to move us out of the cellar with maternal mortality. And infant mortality, we're 47th, so it's not much better. Being able to teach them high-risk deliveries and how to manage these breech deliveries and these shoulder dystocias, and teaching them all neonatal resuscitation. These are the little things that EMS can do to make sure that they are filling in those gaps. It's only going to get worse. Those gaps are going to get bigger. These deserts are going to grow, and we exist out there. So you got to think of yourself as healthcare. We are mobile healthcare out there in these rural communities. So we have to elevate our game to make up that gap.
Yeah, and for all the urban systems that we have, I don't know what the ratios are, but the rural systems to urban systems, I'm sure the number of rural systems is probably quite a few more than urban. Yes. Urban may have a lot more ambulances, maybe more staff, but there's a higher number of systems that operate in these rural areas across the country. And so we really do have to get into this mindset of it's not an urban thing. It's not just the urban EMS systems that have the ability to do these things that really need to be challenged and pushed to move forward. It's the rural systems and the super rural, because we have a tremendous ability to impact the patient outcomes.
Yeah, most of the EMS agencies around the nation, there's about 25,000 EMS agencies. The vast majority of them serve rural areas. Not only are most of these emergencies happening out in rural areas because of the lack of good primary care and outpatient resources, for our rural agencies, they're also usually the most poorly resourced, whether that be equipment, salaries, funding, training, education. And so it's kind of the Swiss cheese model lining up to lead to worse care in the rural areas. So it doesn't take much to go learn how to do something a little bit better. Seek out resources, these podcasts or textbooks, or go to some of these conferences where you learn how to update your protocols, how to do quality improvement, how to evaluate the care you're providing and whether it meets the standards. Things like that are pretty low-hanging fruit for some of these rural agencies to step up and be able to provide better care for their communities.
So as we kind of close out here today, we've talked about a lot of different things. We've talked about NAEMSP in your local chapters, not just in Arkansas or North Carolina, but pretty much every state has a chapter of NAEMSP. And so that's only one agency or one organization you could potentially be a part of. Being involved in your ambulance association or whatever it is that your state has, advocating at the state level, either yourself or through others, those EMS days on the Hill, those kinds of things that you have in your respective state. Let's start being proactive for ourselves. So I always like the last word, the best word, to be with our guest for today. So as we round out here, what do you want our listeners to take away from our conversation today?
I think back to my beginnings, just wanted to give back to the community, became an EMT, loved it, continued to grow and develop my skill set, and just never stopped learning, always stayed clinically curious. I think that's what drives a lot of the work that I do. I serve many masters. I think I have over 2,300 providers that I oversee between many different agencies, ground, air, fire base, law enforcement, so lots of different things. And for me, it's just the clinical curiosity. And I really hope that our professionals that are listening to this, you're out there running call after call after call. The grind can get you down, and sometimes you lose sight of why you got into this in the first place. It's important to try to keep your barometer right there in your focus of trying to improve systems of care. And if you lose sight of the forest through the trees, each individual tree may beat us down, but it's trying to improve the systems of care and staying clinically curious. Find what motivates that drive and hold on to it with all you got, because this job, man, it can beat us all down. Give me 3 straight shifts in the ER and I get it. I see the same patients you guys do. It's a beat down, but I always try to keep that focus. It's good for our mental health, kind of keeping an eye on the bigger picture of why we're doing what we do.
Well, that's it for this episode of the Red River Medic podcast, where we break the rules, we challenge the norms, and we try to save lives. I want to thank our guest tonight, Dr. Brandon Morshedi, for some great insights on what's going on not only at the state level but at the national level. And I love that ending message of just keep persevering, keep going. Your job is meaningful and it is important. Remember, leadership isn't about titles. It's about action, attitude, and having the guts to do things differently. So if you like what you heard tonight, share this podcast, and let's be the change that we all need and we all want in EMS. Stay curious, stay bold, and never stop learning. We'll catch you next time. Same river, same chaos, new ideas. Have a good night, everybody.